we would talk about carcinoma pancreas, whether we have to give any neoadjuvant treatment, neoadjuvant chemotherapy, neoadjuvant chemoradiotherapy, then of course any perioperative treatment, and then finally after you've done the surgery, which is the definitive treatment, whether you have to give any chemotherapy post that. So the background is that unfortunately surgical resection is curative in merely about 15 to 20% cases. And among them, even with R0 resection, the prognosis remains poor. And optimally timed adjuvant and neoadjuvant therapy in various settings helps to improve these outcomes. And how they improve, first let us go to the neoadjuvant therapy. So the obvious question comes when you have a patient with CA pancreas, why do you want to give neoadjuvant therapy? It is early selection of patients with aggressive biology, because the more aggressive they are, the more systemic they become. Treatment of occult disease, which cannot be diagnosed by any investigation, whether it is CT, PET or MRI. And of course, the reduction of tumor size, increase likelihood of microscopically radical resection that becomes more amenable. Another rationale is that if you give neoadjuvant chemotherapy like FOLFIRINOX, it demonstrates a biological effect indicating that even after upfront surgical resection, there is a microscopic disease on which chemotherapy works. And the flip side is that even after apparently successful surgery, there is an early fall-off in survival due to death from disease progression in patients treated with upfront surgery. So these are the caveats for which you give neoadjuvant treatment. So there was an evaluation by the American College of Surgeons from the National Cancer Database that demonstrated that up to 60% of patients undergoing upfront surgery, adjuvant therapy, it was unfortunately omitted due to post-operative complications. So these are the data which we had, and of course, the R status, it counts, because very, very rarely do you have cases where you have a copybook case of a CA pancreas in which you can do surgery and you can give adjuvant treatment. And there is a definition for the resectable and the borderline resectable pancreatic carcinomas, and tumors which are considered technically resectable with or without vascular resection are at a high risk for positive surgical margins when pancreatectomy is performed. So that is why this role of neoadjuvant treatment comes, and this has been incorporated into the NCCN guidelines, where you have a resectable, you have a borderline resectable, and you have a locally advanced disease. So what are the prerequisites? You always have to have a biopsy proof whenever you go for a neoadjuvant setting. And for patients who present with obstructive jaundice, you have to have a durable biliary decompression prior to the treatment which is going to be done. Now you have a lot of combinations and permutations whenever you go for neoadjuvant treatment. You can give chemoradiotherapy plus surgery, you can give surgery alone, you can give chemotherapy alone, you can give radiotherapy alone, or you can give all of them together. And of course, you have the newer evidences to spike the whole pie. So let us go one by one. The first question which we have to answer, neoadjuvant chemoradiotherapy versus surgery. So you have a patient who is loco-regionally advanced. Whether can you give this patient neoadjuvant chemoradiotherapy or not? There are oncological benefits for neoadjuvant chemoradiation, and this was seen in this trial in which gemcitabine-based chemoradiotherapy was given versus surgery upfront in these patients. And if you see here, the 2-year survival, it is there is a difference of R0 section, which is quite remarkable. That is 50% versus 20%. There's another study which is the PREOPANC study, in which patients who were borderline resectable, they were taken up for upfront surgery followed by chemotherapy, or they were taken up for chemotherapy and chemoradiotherapy followed by surgery and again followed by chemotherapy. And they found that preoperative chemoradiotherapy for resectable or borderline resectable patients did not show a significant overall survival benefit. Although the outcomes of surgery endpoints and predefined subgroup analysis suggest an advantage of neoadjuvant approach, but more data is required. And these were the trials again. This was a trial in 2017, one of the first meta-analysis to support the survival in these patients with neoadjuvant CTRT. And there's another study in which you had two sets, if you had resectable versus borderline resectable disease, and the median overall survival favored neoadjuvant therapy over upfront surgery. That was about 7 months difference in patients who were taken up for upfront surgery versus the patients who were given neoadjuvant treatment and then taken up for surgery. So now we have seen neoadjuvant chemotherapy versus surgery. Now let us see whether there is any difference between neoadjuvant chemoradiotherapy versus neoadjuvant chemotherapy. So we are trying to cone it down. First we compared it with surgery, then we compared it with CTRT versus surgery. Now it is whether CTRT is good or chemotherapy is good. So this is the trial in which preoperative FOLFIRINOX, that is chemotherapy, plus minus RT was given for borderline resectable cancer patients. And here if you see the R0 resection which is there, I like to point out here, R0 pancreatectomy was in about 42 patients versus 25 patients who were given neoadjuvant chemotherapy. The clinical impact and chemoradiotherapy, again you can see the patients who were given neoadjuvant chemoradiotherapy versus neoadjuvant chemotherapy, the resection rate was higher in patients who were given the chemotherapy prior. After this, there was a network analysis, again this was done in 2019, in which 14 studies were pooled. And that's said, which is very, very important here, I would like to highlight, for R0 resection, neoadjuvant chemotherapy has the highest probability. For overall survival, you have the neoadjuvant chemotherapy. So if you're looking at a survival benefit, you go for neoadjuvant chemotherapy. If you're looking for resectability, you go for chemoradiotherapy. So that was the decision here. Now we have sifted it down from chemoradiotherapy versus chemotherapy. Now we are going amongst the chemotherapy drugs, which one is better? So you have the modified FOLFIRINOX, which is the standard of care as of now, versus gemcitabine and nab-paclitaxel. So these were the study which was done, and there was no difference in the metastasis-free survival or the overall survival in these patients who were compared between FOLFIRINOX and gem-nab-pacli. There was another study which was done, but this showed that FOLFIRINOX was to increase the overall survival by about 5 months as compared to gem-nab-pacli. So we have seen the combination of the different chemotherapy drugs. Now we pit what is the difference between chemotherapy or chemoradiotherapy when you give this to the patients of CA pancreas. This is the CONCO 007 trial, which investigated the role of chemoradiotherapy versus chemotherapy. And this was the design in which you gave the patients chemoradiotherapy or you gave only chemotherapy in these patients. And here we find that when you give chemotherapy or chemoradiotherapy, you find the overall survival is almost the same in these patients. So the conclusions were that PFS and OS were similar for patients whether you give chemotherapy or chemoradiotherapy. And the investigators concluded that induction chemotherapy followed by additional chemoradiotherapy and surgery in unresected patients of pancreas. The 5-year overall survival rate was 9.6 and up to 26.9 in a selected group. Mind you, in a selected group, not in the ITT set. There's another study, FOLFIRINOX followed by individualized chemoradiotherapy for borderline resectable patients. In this, you find that these patients had a R0 resection in about 65% times. So that is what we sometimes follow in our patients. You have a patient who has a loco-regionally advanced chemotherapy, CA pancreas. You give chemotherapy 4 cycles. If you find that the patient is resectable, then you go for surgery. If you find that the patient is still unresectable but is responding to chemotherapy, then these are the patients who are subjected to chemoradiotherapy, and probably you're able to salvage out more patients in this setting. So switching gears, now we go to perioperative chemotherapy, and you find that when you give perioperative chemotherapy, the primary endpoint of median disease-free survival is almost the same in these patients. Single fraction stereotactic body radiation therapy and sequential gemcitabine for treatment of locally advanced pancreatic cancers. There was a median survival benefit of about 11.8 months, but again, that is subject to the higher studies. So to summarize, neoadjuvant therapy is an approach where the patients can be made resectable. You have to see whether you have to look for overall survival or you have to look for resectability. If you have to look for resectability, then you have to give chemoradiotherapy. If you have to look for overall survival, then these patients should be subjected to neoadjuvant chemotherapy alone. So, patients who are upfront clinically resectable surgically, they should never be given a neoadjuvant approach. That is very, very clear. Those patients who have some caveats, there's some technical considerations regarding surgery, they are the ones who should be taken up for the neoadjuvant approaches. And this has been incorporated in the NCCN guidelines. And as I said, upfront resection in patients with borderline resectable disease is no longer recommended because these patients, the disease has to be reduced. Role of chemoradiation with more active chemotherapy, there are more regimens which are to be seen. And the PREOPANC trial showed that the DFS rates, if R0 resection is unresectable in borderline cases are there is no OS advantage. So these are the guidelines. I think all of you can go and see which are the recommendations. The best chemotherapy protocol is modified FOLFIRINOX. If the patient is not fit, you can give gemcitabine and nab-paclitaxel. Or sometimes the patient is not that fit again, you can go for single agent 5-fluorouracil, or you can give capecitabine in these patients. Along with that, you have to do, if the patient has a strong family history, you should do a BRCA1 and BRCA2 mutations, because subsequently, as a follow-up, as a maintenance protocol in locoregionally advanced patients, you can give PARP inhibitors in these patients. And there are studies in which you should look for certain molecular markers like microsatellite instability, or you should look for tumor mutational burden. And if that is there, then immunotherapy can be incorporated in these patients of locoregionally advanced CA pancreas. Now, switching gears again, now I come to the adjuvant therapy. We had been talking about neoadjuvant therapy. And here you have the SPAC3 trial, which definitely showed that if you have chemotherapy here in the adjuvant setting, definitely there is a median overall survival benefit, and also there is a progression-free survival benefit. Now the drugs, which are the drugs? If you give single 5-fluorouracil, then you have a benefit of about 23 months. And if you give gemcitabine, you have a benefit about 23.6 months. The treatment-related serious events were definitely better when you gave gemcitabine versus 5-fluorouracil. So this was the SPAC3 trial. This was followed by SPAC4 trial. In this, the question was asked whether you have to give gemcitabine alone or you give a combination of gemcitabine with cisplatin. And this was the trial design in which you gave a single agent versus 2 agents. And here you find that the OS was much better when you gave 2 drugs as compared to 1 drug. So the standard came for the adjuvant setting as gemcitabine and capecitabine, or gemcitabine with 5-FU in patients with CA pancreas. There's another trial, that is the PRODIG 24 trial, in which now, so you are going from 5-FU, then you're going to gemcitabine, then you're comparing gemcitabine and 5-FU. Now you're comparing gemcitabine with FOLFIRINOX, which was used in the neoadjuvant setting. So this trial again showed that there was a remarkable improvement in the median OS benefit. So you can see almost 30 months benefit with a very robust hazard score of about 0.64 and a p-value of 0.003. So this definitely showed that in the adjuvant setting, either you can give FOLFIRINOX or you can give gemcitabine plus capecitabine in these patients. So patients who are really fit, they can be given FOLFIRINOX. Patients who are not relatively fit, they can be given gemcitabine plus capecitabine. And patients who are still on the lower rung, as far as the performance status and the general condition is concerned, these patients can be given the capecitabine alone. There is another Japanese trial, that is the JASPAC trial, which showed that S1, which has not been used much, and now again it is available in our country. I don't know whether it is available in Bangladesh, it's not available. So this is another good trial which showed that you had a 2-arm study in which gemcitabine was pitted against S1, and it found that it was having a numerical benefit as far as the overall survival was concerned. Now, adjuvant chemotherapy, the role of gemcitabine-based combinations, I have already told you, and it has been shown that in the assessment, in the intent to treat population and also the pre-specified sensitivity analysis, you find that there is not much difference when you give gemcitabine alone in these patients. However, there are specific categories. What about the elderly patients? Most of the times we find that these patients are in a poor general condition, but in elderly patients also, there was a data in PRODIG 24 trials in which the effect remains significant when you do the propensity score and the hazard ratio favoring adjuvant chemotherapy. So, elderly does not mean age, it means fitness, and there are now different criteria by which you can see the fitness even in elderly population, and they seem to benefit almost similarly as compared to a young and a fit patient. Now we see the guidelines that whenever you give surgery to a patient upfront, invariably the guidelines say that universally all these patients have to be given chemotherapy as an adjuvant in CA pancreas. There can be a doubt in stage 1 disease where the benefit of adjuvant chemotherapy may be questionable in some subgroups. So that has to be sifted out, because unlike other cancers, in this, whenever you do surgery in a patient of CA pancreas, invariably you have to give a adjuvant treatment, whether it is gemcitabine with capecitabine, or you have to give modified FOLFIRINOX, or probably single agent capecitabine. Adjuvant chemoradiotherapy, I have told earlier that these are the trials, but there is no consensus of giving adjuvant chemoradiotherapy in patients with CA pancreas, although there is a definite consensus for giving chemotherapy in patients of CA pancreas. And these are again certain studies to show that the intergroup trial, which again showed that only chemotherapy is beneficial as an adjuvant setting and not in the chemoradiotherapy group. So I think to summarize, the CONCO trial showed a significant improvement in the DFS and the OS with the use of post-operative gemcitabine. And SPAC showed that there is a definite improvement when you give single agent. And SPAC 4 showed that when you combine gemcitabine with the capecitabine, you get a better benefit. So you have an adjuvant setting, you have a super fit patient who's good physical condition. In this patient, you give FOLFIRINOX. You have a patient who's less physically fit, you give gemcitabine and capecitabine. You have a patient who's a slightly lower rung than these two sets, then you can give only capecitabine. And these are the preferred adjuvant treatment guidelines which I've just mentioned. Either you can give 5FU, or you can give gemcitabine, or you can give FOLFIRINOX, or sometimes you can give gemcitabine and nab-paclitaxel. So I think I'll stop here. I thank you for your patience here.